Good afternoon to everyone. It's a great pleasure to moderate today a very important educational webinar entitled The Obstetric Manifestations in Past and Present APS Classification Criteria with the question, what has been changed? The impact of the new 2023 EULAR APS classification criteria and the changes compared to the previous ones, the Sydney criteria, on the classification and management of obstetric APS manifestations will be discussed by two experts from two different medical specialties, Professor Gerard Espinosa and Dr. Núria Baños, an internal medicine and almost rheumatologist, and an obstetrician, respectively. Professor Espinosa is a consultant in the Department of Autoimmune Diseases at the Hospital Clínic in the University of Barcelona. His research work primarily focuses on complex autoimmune disorders, mainly SLE and APS, and he has published with their team several seminal papers in these fields. Dr. Núria Baños is a specialist in maternal and fetal medicine and works in the Center of Barcelona Center for Maternal, Fetal and Neonatal Medicine at the University of Barcelona, Spain. Before we start, I would like to inform you that participants can submit their questions in the chat, which will be addressed by the speakers after the end of the presentation. So we can start with Núria.
Okay, thank you. I will start sharing the presentation. Sorry. Sorry from the beginning. Now.
Yeah. Full screen.
Okay, you can confirm that you can see correctly the presentation?
Okay.
Yeah?
Yes.
Okay. Okay, so, well, good afternoon to everybody. First, I want to thank the organizers to invite us. As Maria has explained, the talk will be conducted by Gerard Espinosa and myself. We work together, we visit together, in fact, in the same consultation, the pregnant woman with autoimmune systemic diseases, which obviously include the obstetric antiphospholipid syndrome. So we experience firsthand the difficulties in classifying and managing obstetric APS. We declare no conflicts of interest regarding the topic of the webinar. We will start, as you can see here, reviewing a little bit how the obstetric antiphospholipid syndrome classification criteria have changed over time. We'll talk also about the impact of these new criteria in real life and how we should manage women who do not meet the classification criteria. We'll also introduce the concept of the non-criteria obstetric APS and explain a little bit our experience with this group of women. As all you may know, the first APS classification criteria were proposed in 1999 and updated in 2006 in the so-called Sydney criteria, which have been widely used in recent years. In 2023, there was another update, which involved some modification with respect to the previous, which we will review point by point in this presentation. First, it's very important to remark that the main aim of the new classification criteria was to develop a new rigorous classification criteria to identify patients with a high likelihood of antiphospholipid syndrome for research purposes, and this is very important. In phase 1, there were 261 items that were selected through systematic reviews and surveys among experts. In phase 2, 27 items were selected and organized in 6 domains. And finally, in phase 3, these criteria were applied to real-world cases for further refinement, organization, and weighting. It's very important to remark that in this new classification criteria, there was the introduction of the weighting in the classification process. Finally, in phase 4, specificity and sensitivity were assessed in 2 validation cohorts. And as we can see in the 2023 classification criteria, there was a higher specificity, almost 0.99, but a much lower sensitivity compared to the Sydney classification, which is about 0.84%, so much lower sensitivity. Regarding the 2023 criteria, as you all may know, there's an algorithm in order to classify the patients. First, we must document what clinical criterion and a positive antiphospholipid test. If the patient doesn't meet these requirements, we cannot continue with the classification process. And if the patient meets the clinical and lab criteria, then we must apply the weighting in order to finally classify the patient. It's very important to remind that we will only classify patients as APS if they score 3 points, both from the clinical and from the lab domain. So in this lecture, we'll compare the obstetric domain 4 from the 2023 classification with the so-called pregnancy morbidity from the Sydney criteria. Regarding prefetal and fetal death, in the Sydney criteria, we need 3 or more unexplained consecutive spontaneous abortions below 10 weeks of gestation, which is the same that in the new classification. So also 3 or more consecutive prefetal deaths below 10 weeks. But in the new classification, this item weighs only 1 point. The other item in the Sydney classification was 1 or more fetal death above 10 weeks of gestation. And in the new classification, we divide this item in 2. So between 10 and 16 weeks, we need not 1, but 3 or more consecutive fetal deaths between 10 and 16 weeks, and 1 or more fetal death between 16 and 34 weeks of pregnancy. But these 2 criteria only weighted 1 point. So to summarize, in the new classification, the prefetal or fetal deaths without preeclampsia or placental insufficiency with severe features do not meet the clinical criteria to be classified as obstetric APS. And also fetal death above 34 weeks does not meet neither the criteria to be classified as obstetric APS. Let's move to the preeclampsia and placental insufficiency criteria. In the Sydney classification, we need 1 or more premature births before 34 weeks due to a severe preeclampsia or placental insufficiency, while in the new classification, the clinical criteria is to have preeclampsia with severe feature or placental insufficiency with severe features diagnosed before 34 weeks of pregnancy. And this weighted 3 points. The other item is preeclampsia and placental insufficiency, so we have to have both diagnosed before 34 weeks, and this weight 4 points. To summarize, in the new 2023 criteria, the placental insufficiency features, as we will see later, are much more detailed, and the postnatal weight below the 10th centile, but without placental insufficiency features, is not included as a clinical criterion for obstetric antiphospholipid syndrome, and it was included in the previous classification criteria. Just a quick review of the severe features of placental insufficiency. We define a placental insufficiency with severe features when we have an intrauterine fetal growth restriction, so an estimated fetal weight below the 10th centile, and an abnormal fetal surveillance test. And then we deliver the baby, when we diagnose it, an abnormal Doppler, and here we deliver the baby around 32, 34 weeks, and oligohydramnios, and we deliver the baby at 37 weeks, or a severe intrauterine fetal growth restriction, so an estimated fetal weight below the 3rd centile, and here we deliver the baby at 37 weeks. And also a new criteria that has been introduced in the new classification is the finding of a maternal vascular malperfusion on placental histology. And so to sum up, there's not a perfect classification, and there's always pros and cons. The pros of the new classification criteria are that they are more effective identifying individuals who do not have APS, so it reduces the false positives. It's more precise identifying patients who are affected by APS, so it increased the true positive. It ensured that those included in research studies are more homogeneous in their APS presentations, and the criteria also recognize the complexity of APS by distinguishing between classification and diagnosis. In cons, the sensitivity, as we explained before, is much lower than in the updated in the Sydney criteria. It increased the false negative cases, and it could lead to an underdiagnosed if it's used for diagnostic purposes. That it's very important to remind that this is not the aim of this classification. It could also be emotionally challenging, and we see it in the consultation very frequently, that for women who have relied on an APS diagnosis to explain their recurrent early miscarriages. And it's also a little bit more complex classification, especially for the waiting. And just to make a little bit easier, we can summarize that only the preeclampsia or the placental insufficiency with severe features diagnosed before the 34 weeks of pregnancy could be finally classified as obstetric antiphospholipid syndrome for research purposes. And now Dr. Espinosa will continue with the talk.
Okay, let's continue. So far, Núria has presented and described the evolution of the classification criteria for obstetric antiphospholipid syndrome over the time. But what is the real life impact of this new criteria in the real life? Well, on the one hand, in the original description, experts highlight the group of women with obstetric morbidity, but who do not meet classification criteria. This group of women that scores only 1 point in the obstetric clinical domain. Women with unexplained 3 or more consecutive prefetal deaths or early fetal death with any other clinical criteria and laboratory criteria. And in the other hand, those women with otherwise unexplained 1 or more fetal deaths. With no other clinical criteria and fulfilling the laboratory criteria. Next slide. On the other hand, there are some obstetric manifestations that have been associated with antiphospholipid antibodies, but they are not included in the new EULAR classification criteria for obstetric antiphospholipid syndrome. And some of these obstetric manifestations are, for example, the late preeclampsia or intrauterine growth restriction after 4 weeks of gestation, the placental abruption, placental hematoma, preterm birth, puerperal preeclampsia, or 2 or more unexplained in vitro fertilization failures. So in the last month, some groups have published the results of studies in which they validate the performance of the new EULAR classification criteria in the large cohorts of patients with APS. And we will present 2 of these studies. In this table, we show again the results of specificity and sensitivity of the new EULAR criteria in the 2 original validation cohorts with results around, as said by Núria, of 99% and 83% respectively. And the first study, next slide, has been performed in China. The study included 436 patients diagnosed with APS according to the opinion of 2 experienced rheumatologists as a gold standard. As you can see, the values of specificity and sensitivity are very similar to those obtained by in the 2 original validation cohorts, but interestingly, 18% of these patients with APS did not meet the new criteria. 38% score less than 3 points in clinical domains, and the majority, again, failed in terms of obstetric clinical domain. Next slide. The second study I will present is a study performed in 2 large research cohorts of patients with APS from Italy and Argentina, 158 APS patients. The diagnosis in this case was according to the 2006 Sydney criteria, and patients were categorized as having APS when applying the new EULAR criteria. Almost half of patients did not reach sufficient composite score when applying the new classification criteria. And in terms of pregnancy morbidity, as you can see in the figure, only 12% of women meet the new classification criteria. And the main reasons for exclusions were, again, the 3 or more early pregnancy loss in about 57% of these women, and fetal death in 80% of women. Next slide. This scenario of women with obstetric manifestations but who do not meet the classification criteria is very frequent in real life. And in our multidisciplinary unit, we are working together with Núria. These are the data of our multidisciplinary unit. The percentage of women with obstetric morbidity but who do not meet the classification criteria has increased in the last 10 years from less than 10% to more than 36%, and this is a situation very frequently. As a summary, the original aim of the international consensus of this international criteria was to standardize multi-center and clinical trials on APS and for research purposes. However, patients frequently do not fulfill the obstetric antiphospholipid syndrome classification criteria, and these cases are known now as non-criteria obstetric antiphospholipid syndrome. However, we are not a formal definition of this non-criteria obstetric antiphospholipid syndrome because there are different clinical scenarios, different scenarios from clinical point of view or the laboratory point of view. So whether women with non-criteria obstetric antiphospholipid syndrome require treatment is a matter of debate. Both studies, for example, the European Registry of Obstetric Antiphospholipid Syndrome and the Italian study named Eureka, suggested that these women benefit from treatment, but we don't know which is the best treatment for these women because there are not appropriately designed studies. Next slide. So next slide. So the question at this moment, next slide.
See?
Yes, is how we should manage women, how we should treat these women with obstetric manifestations with some kind of antiphospholipid antibody profile, but who do not meet the classification criteria. Some answers we can find in this study. This study is the largest comparative study published in 2020. It's the European Registry of Obstetric Antiphospholipid Syndrome. And in this study, the authors compare the main clinical and immunological features, the treatment, and the pregnancy outcomes between 1,000 cases of women with obstetric antiphospholipid syndrome and 640 women with non-criteria obstetric antiphospholipid syndrome. And according to the definitions, patients with obstetric antiphospholipid syndrome had higher number of miscarriages, fetal losses, stillbirth, early placental vasculopathy, and prematurity, whereas women diagnosed with non-criteria obstetric antiphospholipid syndrome presented higher rates of recurrent implantation failure and late placental events. What about treatments and what about the pregnancy outcomes? Next slide, please. Considering the treatment, and as you can see in this table, there are no difference in the types of treatment or combinations of treatment used in both groups of patients. As you can see, low-dose aspirin, low molecular weight heparin, or the recommended treatment for obstetric antiphospholipid syndrome, that is the combination of low-dose aspirin and low molecular weight heparin, are very similar in both groups. And considering the pregnancy outcomes in terms of live births or live births with the recommended regimen, that is the combination of low-dose aspirin and low molecular weight heparin, the results are very good and comparable between two groups. In other words, physicians in real life treat in the same way the two groups of patients with good results. Next slide.
Yeah, and now I continue in our unit. In fact, we also wanted to review and analyze our own data because, in our everyday clinical practice, we have a lot of patients who doesn't meet the clinical criteria. So we conducted a retrospective study in which we review all the patients with obstetric APS and the so-called non-criteria obstetric OPS. We included 207 patients, of which only 16 met the Sydney criteria to be classified as obstetric antiphospholipid syndrome. And in fact, if we do it now with the new criteria, I guess that these 16 will be maybe 5, I don't know. We haven't reviewed with the new criteria. So among the clinical non-criteria features, we included 25 patients with sterility, 21 with 2 pregnancy losses, 18 with recurrent implantation failure, and 1 with a preterm birth above the 34 weeks. As you can see here, regarding treatment regime, both groups were treated also similarly. 87% of the non-criteria and 83% of the obstetric APS received the standard treatment of low-dose aspirin plus low molecular weight heparin. Regarding pregnancy outcomes, as you can see also, live birth rate was comparable between groups, 82.4 versus 75%, and early pregnancy loss was the most frequent obstetric complication in both groups, with 15 versus 20% in both groups. There were also no differences between other obstetric and maternal outcomes, such as preeclampsia or cesarean section. And there were also no differences regarding fetal and neonatal outcomes, such as gestational age at delivery and fetal growth restriction or neonatal death. So taking into account our own data and experience, we can say that there were no differences in demographic features between both groups. Previous history of late pregnancy loss was more frequent in the obstetric APS patients, and recurrent implantation failures and 2 pregnancy losses were more frequent in the non-criteria, which is normal because these are non-criteria items. Both groups were treated similarly, and the outcomes of the subsequent pregnancies were also comparable. And therefore, we conclude, as the European Register also concludes, that these 2 groups of patients may be treated similarly to those with obstetric antiphospholipid syndrome.
Okay, at this time it is important to distinguish the classification of a disease, of an autoimmune disease, for example, versus a diagnosis of the disease or autoimmune disease. Classification of a disease can be achieved by a set of criteria with reasonable sensitivity and specificity, whereas diagnosis is a more complex process, multi-step process performed by a physician, which is difficult to achieve with a single set of criteria. Next, in terms of antiphospholipid syndrome, the diagnosis performed by a physician is based on, first, the antiphospholipid antibodies profile. Second, the strength of the association between antiphospholipid antibodies and the clinical event, thrombotic and in this case obstetric. And third, the potential other causes of the event. And as a consequence, some patients with antiphospholipid antibodies, for example, women with obstetric morbidity, may be treated as having IPS even if they do not fulfill the classification criteria. So as a conclusion, obstetric IPS classification criteria has changed over time with the aim to capture well-defined homogeneous cohort for research, and this is important. Patients frequently do not fulfill the obstetric IPS classification criteria, but the current evidence indicates that women with antiphospholipid antibody and obstetric morbidity that who do not meet the classification criteria may benefit from treatment. However, there are no appropriately designed studies that could better evaluate treatment effectiveness. So thank you very much for your attention, and we are available to answer your questions.
Thank you very much, both for your provocative, let's say, talks, which can open a provocative also discussion. I would start with Núria. And in a slide that you presented, you highlighted the fact that in the new criteria we need actually to have preeclampsia and or placental insufficiency and mainly severe features of placental insufficiency. Could you please comment on that?
Yeah, well, the new criteria, included both, no, preeclampsia and placental insufficiency with severe features. So comment on what exactly the features?
I mean that it's a kind of it's an important question that compared to the previous ones, the new ones are very limited, let's say. The emphasis is on two main features, on preeclampsia or severe preeclampsia or eclampsia, or placental insufficient, because in some criteria the cause of preeclampsia is the placental insufficient again. I mean, the focus is very much on placental insufficiency. What's your experience? You work all these years with these patients. What's your experience? Are there people without these manifestations frequently among APS patients? I mean, the best way probably to respond on this question is that the experience from patients that have already been diagnosed, let's say, patients who had already thrombotic APS. So in this case, we are sure that the patient has APS. Is it always necessary? Not necessary, it's not the correct word. It's obligatory to have preeclampsia or placental insufficiency?
Yeah, well, regarding this classification, in fact, in our clinical practice, the patients with a history of severe preeclampsia or placental insufficiency are the less, no? So the majority of the cases are women with obstetric morbidity in terms of early pregnancy losses. So what we usually see is a woman that has previous severe preeclampsia, and as a study, somebody looked for these antiphospholipid antibodies and they were positive. So in a subsequent pregnancy, well, we recommend the treatment, but but in the daily practice, the more frequent is women with 1 or 2 early pregnancy losses. In much cases, the majority of the cases without a genetic study, which is the main cause of early prefetal or fetal death below 20 weeks of pregnancy, let's say. So the diagnosis, it's really very, very challenging, no? And so, and I think in the new classification is very important, because in the Sydney one, the criteria of placental insufficiency was not that clear. And now in the new ones, it's more specified, so it really helps. But in my opinion, it's very, very restrictive, because even if you have a preeclampsia or a placental insufficiency that has been diagnosed above 34 weeks of pregnancy, you are also excluded, no? So you cannot be classified as obstetric APS. Or if you have had a fetal death, no, at 35 weeks of pregnancy or 36 weeks of pregnancy, you cannot be classified.
That's another point, that even if you, let's forget the recurrent miscarriages in the first trimester. Let's say that everyone sometime in our life was thinking about that. Are they true APS manifestations? Because we all know that there are many, many other causes. Let's say this is the gray zone, the first trimester pregnancy manifestations. But we have another issue that also for the fetal loss that, let's say, manifests during the 16th week of gestation or 20th week of gestation. If this loss is not associated with placental insufficiency, again, the patient does not fulfill the criteria. Even if the pregnancy is after the classic, let's say, gestation week that we know. And if you combine this also with the restrictions in the lab tests that we prove as important, we score actually the cases where only the IgG isotypes are present, or the cases where only lupus anticoagulant is present, or in other words, all the IgM isotype, anticardiolipin and the beta-2-GPI antibodies are excluded. This is the reason why all these patients and the papers that you previously shown, Gerard, have shown a very restricted percentage of the cases that were previously diagnosed as obstetric APS. You refer to a paper that showed that only 12% of the previously diagnosed as APS patients remain to be diagnosed with a new classification criteria as obstetric APS. So there's a combination of the criteria, the clinical criteria and the laboratory criteria that, but on the other hand, the idea is that the classification criteria, as you also stressed, highlighted, is that are produced for research purposes, and the purpose is to standardize patients and avoid some false positive or even negative cases. And it depends on the practitioner's judgment, actually, what's the diagnosis, the real diagnosis. And speaking about diagnosis, we have a question from Professor Tikani. Gerard, can you clarify the diagnostic criteria of obstetric APS?
Yeah, but really, diagnostic criteria, we don't have diagnostic criteria of obstetric antiphospholipid syndrome. The criteria is based on the presence of persistent antiphospholipid antibodies, the strength of association between the clinical event, and as you said, Maria, probably it's not the same, the fetal loss at 28 weeks of gestation because of preeclampsia with severe features than early fetal loss in the first trimester. And finally, the other potential causes of the event. And as Núria said, the most frequent cause of early fetal loss is chromosomopathy. And in most cases, we don't have a confirmation of the existence of the other causes of the early fetal losses. So I think that it's very, very important to differentiate the classification. And okay, I'm sure that these women has a obstetric antiphospholipid syndrome, and the other cases of non-criteria probable obstetric antiphospholipid syndrome, possible obstetric antiphospholipid syndrome. But for example, in the Italian study named Eureka, the authors have demonstrated that low titers of antiphospholipid antibodies may be associated with the clinical events, and maybe these patients may benefit from to treat with low dose aspirin or the combination of low dose aspirin and low molecular weight heparin.
Yeah, and also, sorry, no, I just want to add that, yeah, it's sometimes it's difficult to diagnose. I mean, even if they don't meet the clinical criteria, there are some cases that you are quite sure that they have an obstetric APS, no? If she has a fetal death at 35 weeks without preeclampsia and a persistent positivity, okay, you can say, no, these women have APS. Or if she has 2 pregnancy losses and a persistency with a high titers. But there are some cases, and we also see in our consultation, with only 1 early miscarriage and an intermittent positivity. And these cases, these are the really cases that make us doubt, no? And we sometimes treat these patients, or they are already treated, no, by the in vitro fertilization clinic, and we think that they don't really have obstetric APS.
So that was the actual idea of restriction, let's say, to be sure that the patient has
yeah, there's a wide range of a gray zone, no, because it's very heterogeneous. This non-criteria group is very heterogeneous, and I think this is one of the main problems. Maybe we have to try to subcategorize or somehow, I don't know, no?
Yeah, especially for the first trimester, because we all know that there are many other causes, even for other trimester cases, but for the first one, we should be really sure before we start to treat, because we know that some people, probably mostly obstetricians, send all the panel of antiphospholipid antibodies even after the first abortion.
Yeah.
So in this case, it's really more than a gray zone if the patient should be treated or not. We need more robust criteria. And you have also mentioned the non-criteria. We have three criteria to discuss now. We have the previous ones, the updated support, which were called Sydney criteria, the 2006 criteria, the new criteria, the 2023 criteria, and those that you referred to your slides, to your presentations, as non-criteria obstetric APS, compared to the previous one, compared to the Sydney one, not compared to the new one, correct?
Yeah.
Yeah, all those that are that did not fulfill the previous criteria, the Sydney criteria. So these are less well, let's say, defined, but again, we all feel that some of these patients would probably have obstetric APS and probably need treatment, and we included these cases in the EULAR recommendations for the management of APS. We included this at least two of the non-criteria cases, and we suggested some kind of treatments for these patients. We have another question from Dr. Koutolo, Professor Koutolo. What about a previous history of premature death or preeclampsia before the disease in each patient? The time of therapeutic intervention was similar in both groups. And before he had a provocative question, do you know the critical single criterion that changed the ratio sensitivity and sensibility in a such significant manner in the different classification?
So I didn't understand the end of the question.
So I think there are some provocative questions about what was the criterion that there was such a big change. The procedure was a procedure that we follow in all classification criteria, phase 1, phase 2, 3, item generation, item reduction, and then we had a 1,000-mind exercise where we were for 2 days, for 12 hours per day, the steering committee, in a room where several, that's why it's called 1,000 minds, several questions were discussed. There were some examples for each case, and everybody should respond if this should be considered as APS or not. So based on this, but mostly based on the real life cases from different cohorts, there was that kind of change in thrombotic APS and obstetric APS criteria. Another question that someone could discuss is how this will change also the behavior from physicians. I mean, everybody who read this criteria can start now to probably instinctively to use them as diagnosis criteria. And how the treatment can be changed based on that. I mean, in cases that we felt before that they are real obstetric APS cases, we probably don't use in these cases the treatment that we were used to use before. And how can this change the field? I mean, the treatment, because everything, treatment, classification criteria, recommendation, everything is about treatment. It's about real life. The real life is not something philosophical. We need treatment. How we treat these patients and how the treatment has been changed.
Yeah, well, I think this is the main problem, no? That we have this classification criteria, but in real life they are not useful, no? Because it doesn't really help us to decide how to treat patients. In my opinion, I think that most of the patients are overtreated other than undertreated. So it's true that if we follow this criteria as a diagnostic criteria, no, which we don't have to do, we will undertreat. But what we see in our daily practice is that most of the patients are overtreated. So I think that we don't have to fear about undertreatment, but physicians that see these patients has to be aware that they don't have to use this criteria as a diagnostic one. But yeah, the question then is, okay, and then what do we use as a diagnostic? Because as Gerard say, okay, there are these thoughts that we can follow to have a diagnosis, but there's sometimes we miss some tools, because okay, we have 3 early pregnancy losses with a genetic study. We have this antiphospholipid, and we don't have any other tools or information to take a decision, and to say, okay, I don't have any other information to decide if this patient has or not has obstetric antiphospholipid syndrome. So I don't think there's a risk of undertreatment, because we think that we are overtreating patients. But yeah, and the problem is that these new criteria are so specific that make that all the other ones are treated in a very heterogeneous way. And at the end, what we do, and maybe what we are going to do, is to treat all patients the same. Sometimes before we treated some patients only with aspirin. Now we treat all patients with aspirin and heparin. But assuming that we are overtreating some patients, but we really don't like to do this. And I think that at the end is a very heterogeneous group of patients, all that doesn't meet the classification criteria, that we now are treated mostly the same. But yeah, we have to optimize it. I don't know how, but I don't know, Gerard.
My role as moderator is that I would probably need to suggest the other option also. So if we think that everything that is new make us feel strange, let's say we were used to the previous criteria, we used them for 20 years, 2006 and now 2025. And probably we were used to those, and probably now it's difficult to feel that we need to do something different. And probably the new ones are better, or equal to the previous ones, but we are not used to use them yet. And probably they put some the specificity is increased, so we avoid actually the over-treatment, and we treat people that really need to be treated, and not others that they shouldn't be treated. And of course, everything that is new should be also tested by different ways. One way would be to use the registries that we have. For example, we have the biggest registry, there's a European registry with obstetric APS patients, and see from there, analyze with more modern statistical, for example, machine learning or some other more robust techniques, how all these criteria that were are different now. I mean, the different cutoffs for the antiphospholipid antibody positivity and the different manifestations, how over a long-term follow-up, how they change the treatments or the physical, the nature of the disease in a long-term follow-up, and using a large number of patients. That would be a good idea. We have also the APS action, where many patients are already there. And I read a paper that was published some days ago, I think, that analyzed the percentage of patients that are not fulfilling criteria for obstetric APS from the European Registry on Obstetric APS. 38% of patients had a history of 3 miscarriages, so these patients should be excluded now. Excluded, I mean, excluded from the definition of APS. 23% experienced stillbirth and 12% had a cycloid cardiolipin or beta 2 GPI antibody. And from APS action, again, almost 20% had first trimester miscarriage and 69% a stillbirth after 10 weeks. So we can use all these tools. We have big data, and we can see prospectively the patients, and then we can better understand if these criteria are better than the previous ones. Probably they are, and we will be used to use them more precisely in the future. We need data. We need evidence.
Yes. And this is very important because into the group of non-criteria obstetric antiphospholipid syndrome, there are different clinical scenarios from the clinical point of view, but also from the laboratory point of view. And in our clinical practice with Núria, the number of women with only one positive determination at higher titer, but also then negative determinations, or low persistence of low levels of anticardiolipin or anti-beta 2 are not the same. And another problem is the technique of the laboratory. It's not the same, the ELISA and the chemiluminescence.
Yes.
So there are different clinical scenarios, and probably all these different clinical scenarios maybe should be treated in a different way.
Yeah. We need evidence. We need good evidence to.
Yes.
Maybe we have to define, try to define the non-criteria obstetric manifestations that would be more useful in the clinical practice. No? So, one, it's okay, these two research purpose, and okay, the real life purpose, then we can focus on these patients to select those non-criteria items that are more probably related to APS.
Or analyze the data that we already have in the big registries and see them prospectively from this point of view now. So I think we are close to finish the session. Let's see, check if there are other questions. There is one question, the role of fetal and placental duplex study for APS and preeclampsia, with questionnaire and I think this is the question about the placental insufficiency.
Yeah. Well, there's a well-defined criteria of preeclampsia with severe features also, and placental insufficiency. So this is quite clear to define and classify.
I think that the new criteria are very good regarding the definition of placental insufficiency because for example, for rheumatologists, this was not clear. It's actually clear for obstetricians, but for us, it was not clear what was the definition of placental insufficiency. Now it's very, very clear, and it helps us a lot to understand if there is or not placental insufficiency.
And it also includes the placental histology. So we see it obviously after birth, but if there's a maternal malperfusion on the placental histology, this also supports the diagnosis of APS.
Yeah. So histology is actually another objective criterion. We need objective criteria, and we need other objective measures such as those, the analysis that we can have from big data, from retrospective data and prospective data. This will help us to understand what's the real case. I think we can close the session because there are no other questions. If you would like Núria and Gerard to say something before we close.
Not really. We still have to work on it.
But you posed several questions for thought, and there are many research questions for the future that need to be answered.
Yeah.
Sure.
Okay.
Thank you so much. Thank you very much.
Thank you very much.
It was very good, I think. Very interesting and very interesting questions and answers, if there were answers to every question, in this case, in a very hot topic.
Mhm.
Thank you so
Thank you,
much.
Ed.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.